All right, here we go. Let's make this pretty challenging, but still manageable. 69-year-old man presents to the emergency department with sudden onset of confusion and right-sided weakness. All right, he's got a long-standing history of controlled hypertension and hyperlipidemia. And neurological exam shows a right facial droop and hemiparesis. Look at that blood pressure and the pulse. And the patient is diagnosed with acute ischemic stroke, and the blood pressure control is initiated prior to the therapy. Shortly after IV administration, his vital signs show his stroke volume is unchanged, systemic vascular resistance is decreased, and his heart rate is decreased. Which agent is most consistent with these hemodynamic findings? All right, so this is a pretty tough question, but we're going to break this down here. And before we do this, I just want to talk. So try to answer this question. Really, 3, 2, 1. Okay, got it. The answer is going to be Labetalol. So let's talk about this. So there's no change in stroke volume, decreased SVR, decreased heart rate. Labetalol is a mixed and adrenergic blocker. That means that it blocks beta 1 receptors in the heart, beta 2 receptors in the lungs and in some vessels, and alpha 1 receptors on the blood vessels. So it's a 3-in-1 drug that calms the heart and opens up the blood vessels. That alone will get you the answer. But labetalol, you think of the beta blocker, but it's also got a little bit of A in it. So labetalol, because it's got the A there too. All right, so how the receptor blockades work. So alpha 1 blockade will decrease the systemic vascular resistance. Alpha 1 normally constricts them, right? And so we know that that's going to be alpha 1 blocked. That's the reason that we see the reduced SVR. Beta 1 blockade, that is found in the heart. That will increase the heart rate and the contractility. And so if you give labetalol, it'll make the heart slow down and lower the heart rate. Contractility is reduced. That's where the heart rate goes down. Why doesn't the stroke volume drop? So normally if contractility goes down, like with beta blockers, you reduce the contractility, stroke volume might decrease as well. But with labetalol, the afterload is lowered because the afterload is the resistance that the heart pumps against. And so the stroke volume might decrease, but with labetalol, the afterload is lowered because of the vasodilation. It's like, here, get out of the heart. It's fine. So the heart doesn't have to work as hard to push all that blood out. And so then you maintain the stroke volume. You're chilling. You're still getting it out. Why? Because of that SVR decrease, right? The SVR decrease because of the alpha 1 antagonism of labetalol. So why doesn't the stroke volume drop? It's because labetalol is making sure that the stroke volume is retained because the afterload is decreased, the pressure. That the resistance the heart pumps against is decreased. What about reflex tachycardia? So usually when the blood pressure drops, then you get a baroreceptor reflex that increases heart rate to maintain perfusion. But labetalol's beta 1 blockade will prevent that. So when the vessels dilate and pressure drops, the heart doesn't speed up. So that's why the heart rate goes down instead of up, like other vasodilators. So recap. SVR resistance goes down because of the alpha 1 blockade. Heart rate goes down because of the beta 1 blockade, slows the heart. Stroke volume is unchanged because the afterload of our alpha 1 antagonist effects. And so that's going to be our lowdown for this question. That's the reason that we see what we see in this question stem. Now, a lot of these other answers, like hydralazine, that would be an arterial dilator, and it does not have venous effect. So SVR, this is arterial. All right, labetalol, metoprolol. Let's talk about this one. Metoprolol is a beta 1 selective blocker with no alpha effect. Just a classic salt of the earth metoprolol. And that lowers heart rate and contractility and decreases stroke volume. No vasodilation. SVR unchanged. All right, nitroprusside, that releases NO, and that causes balanced vasodilation in both the arteries and veins. And so it'll decrease the SVR, but the heart rate increases. And we see a heart rate decrease here, so not nitroprusside. That would increase the heart rate. So because, you're increasing the heart rate in nitroprusside because you get that vasodilation, and in nitroprusside is used in hypertensive emergencies because the risk of the cyanide toxicity will limit its use for long infusions. And so yeah, this is different because your stroke volume would be usually increased, and your heart rate would also increase because of the reflex of decreasing that pressure. So it's just going to have the heart rate go up because there's no alpha-1 antagonism for nitroprusside. Phentolamine is a non-selective alpha blocker causing vasodilation. So you would see that drop in the systemic vascular resistance, but it's used in catecholamine excess, like a pheochromocytoma or Maui crisis. Okay, labetalol is a mixed blocker, so hypertensive emergencies, because when heart rate control is also needed, because it reduces the SVR without causing reflex tachycardia due to its beta-1 effects. So super awesome medicine, and that's pretty much all we got here, folks. If this was helpful, then like and subscribe. Leave a comment on how to improve the videos.